And there you go. You might get a little notice as I'm recording. So that we have this available for folks who can't be here. Okay, I'm ready. Throw it at me. What do you want to know? You guys hear me?
Yes. Hi. Yes, we can hear you.
Okay.
One of my questions was in one of your slides, it I believe it's about hydrochlorothiazide, and it was asking what's the best way to like measure the effectiveness that the drug is working. And so it says that their blood pressure was self-reported and it like had gone down from their previous levels. So the best way to judge that would have been weight loss. But if their blood pressure wasn't self-recorded, would that be the best way?
Yeah.
Okay,
Yeah.
because the book says that that would be the best way. So I was just checking that the reason it wasn't the best was because it was.
Yeah.
Okay.
I was just trying to get you to think more about fluid status.
Okay.
And fluid status, oftentimes people will say, oh, well, you know, we measured the I's and O's. Well, I's and O's can be very, sorry, let me keep letting people in, can be very inaccurate.
Mhm.
And so that's why I tend to want to know more like weight loss is that, you know, weight loss or weight gain, those are hard to refute as long as you're using the same scale.
Okay.
But blood pressure is fine too. And again, it doesn't mean that we would totally ignore what a patient says. That's not the case either, but we might not make like sweeping, you know, decisions based on just a patient's blood pressure. Does that make sense?
Mhm.
Yeah.
Thank you.
Yeah. What else do you guys want to know?
I have a question.
Yeah.
So on the slide talking about digoxin, it says that you have to be careful using potassium sparing diuretics for hypokalemia.
Mhm.
But should
Wait.
you also be
Are you sure it says
potassium wasting
Okay.
diuretic? But would you also, it doesn't say specifically potassium wasting, so would it be all diuretics or specifically potassium wasting for digoxin?
Well, dig toxicity tends to happen in, tends to be more possible in a hypokalemic state. Does that make sense? So if you're taking a potassium wasting diuretic, you're more at risk for dig toxicity. Does that make sense?
But would you still want to monitor potassium levels with a potassium sparing diuretic for digoxin, or does it matter as much?
You probably still want to look, you know, you probably still want to check it periodically. But we're not as worried. Does that make sense? Okay. I'm going to get myself to a point where I can open you guys' slides too if I need to. I've been a recording fiend. They all start to sound kind of weird. You'll know why. I'm like, hit myself. What else? Can anyone tell me why patients start Coumadin and Lovenox at the same time? They need anticoagulation after, oh, let's just say a PE, a pulmonary embolism.
Lovenox is more of a short-term drug that you kind of only would take in the hospital or very short-term after like leaving the hospital. And so you put you on warfarin at the same time so that it prevents any future clotting episodes in like the more long-term future. But Lovenox is more in the short-term future of preventing any more clotting.
How
episodes.
far out long-term future?
For which one?
For warfarin.
Well, in the lecture, you said that people should stay on warfarin for up to 6 months after a clotting episode.
But the real reason, so you're getting close. The real reason that you start this 2 at the same time is that Lovenox is going to start working right away to prevent clots. Warfarin's going to take 3 to 5 days to begin working. But remember, warfarin's oral, Lovenox is sub-Q. So we don't really want to send the patient home on something they have to do sub-Q for the next 6 months. So we start them on Lovenox and we start them on Coumadin, but we know that Coumadin/warfarin, sorry, it's just a habit, is not going to kick in for 3 to 5 days, which is why you start them on Lovenox. And once the warfarin kicks in, the Lovenox can go bye-bye. And now your patient's only on warfarin, which is an oral tablet taken every day for 6 months. Does that make sense? That's a really important point to know. Why are they on 2 anticoagulants at the same time? Because common sense would say, oh my gosh, they're going to bleed if I do this. But one's not working for 3 to 5 days. The one's taking it, one's doing the job while the other one gets, kind of like gets ready to go. And then once that other one is up and it's at a therapeutic level, then we can take away the Lovenox, which is sub-Q. We don't want to send them home with sub-Q. That means we've got to send them home with needle boxes and stuff to do injections and blah, blah, blah. Sometimes we do. Patients are really doing well and we think they're going to have to take Lovenox just for another couple of days. Then it's like, yeah, okay, we'll send you home. And you're going to continue to take the 2 until someone calls you after evaluating your what lab would they be looking at to determine whether you're ready to stop Lovenox and that your Coumadin is kicked in and working now. What's the lab?
INR.
INR, thank you. Okay, so perfect. The patient, if they happen to go home on both, which frankly, I think is happening a lot more these days because we don't let patients stay in the hospital very long anymore. Then as you can like blink your eyes and lift your own spoon, you're out. So, but in the old days, patients would stay on, they'd stay in the hospital until their Lovenox is discontinued and they just go home on their warfarin. Make sense? Okay. Cool.
And then in regards to that, so we would only use regular heparin, not very much, like just before a surgery is all it kind of says. Okay.
Probably the biggest thing that heparin is used for right now, regular heparin, is for anticoagulation of catheters, but big catheters, like dialysis catheters or central lines that are put in, kind of like the one that I gave a picture to you of. Those can't be kept open with saline, like a peripheral IV can. Peripheral IV, you can keep it open with just saline, and that works really well. You just put saline in. I can't remember what the frequency is. Let's say it's every 8 hours, right? Just to kind of keep it patent and ready to be used. But especially if it's not being used, if it's capped off, right? And it's just there in case you need it. But that doesn't work for those big catheters. Those big catheters need heparin. The only other time you would use heparin is something very atypical, like I know we used to use heparin to try to prevent something that you guys know nothing about. It's called graft versus host disease. Happens after transplant. You're trying to keep the liver kind of clean and clear because it can get kind of filled with all the muck that happens with bone marrow transplant. So we used to do heparin for that. It's not terribly effective. So I don't think we do a heparin group anymore, but yeah, it's not used much. It can be used as a bridge for surgery, like I said. Like if you, let's say I'm taking, Coumadin, and all of a sudden I need to, I need to have some, blow out my knee and I need to have knee surgery. I can't walk, right? So what they'll do is then they'll start me back on heparin, probably on Lovenox. They might even do regular heparin, but probably Lovenox. And they'll keep me on Lovenox. And then the goal will be to take away my Coumadin. And then because Lovenox only works for 12 hours, I'll take Lovenox right up until 12 hours before my surgery. Then I won't take it. Then I'll be, normal for my surgery. And then as soon as my surgery's over, I can go back on Lovenox, start my Coumadin again, and 3 to 5 days later, stop taking my Lovenox. Does that make sense? It's kind of weird, but I mean, it happens all the time. My husband actually had to have a colonoscopy while he was on his Coumadin, and that's exactly what happened. So he went back on Lovenox for a few days, got himself, to a point where he could stop, which as soon as the Lovenox is not working, after those 12 hours, your INR is going to correct back to normal. Then he had his procedure, and then the very next day he started Lovenox and Coumadin again. Took his Lovenox for, I want to say, like 4 days, and then stopped and just kept back on his Coumadin for the rest of the 6 months. Okay.
I have a clarifying question. Sorry.
Yeah.
So I know INR really reflects the warfarin levels, and the active partial thromboplastin time. That one represents heparin.
That's
And
right.
So if the Lovenox, whether it is introduced or extroduced, it won't change the INR level. It's only the warfarin that'll
Right.
change the INR
That's
level.
right.
Okay.
It's only the warfarin. And it's just because Lovenox with that low molecular weight, it's still probably affecting the APTT, but we're not measuring it because we know with Lovenox that we're not going to get these wild swings in APTT like we would with heparin or like we can with Coumadin. Well, Coumadin would be, again, INR, but so when they're on low molecular weight heparin, because they're almost always on Coumadin at the same time, we're not going to be measuring. Yeah, we're not going to be measuring. We're only going to be measuring INR. Does that make sense? What's a normal INR? What do we have? What do I have right now? What should my INR be? 1. And if I'm anticoagulated appropriately, it should be between 2 and 3. Right. So anything above that means that I'm over anticoagulated. Right now, I'm at risk for bleeding while I'm anticoagulated, but I'm really at risk for bleeding when I'm over anticoagulated. Okay.
I have a question. So I've kind of heard a few numbers being thrown around, and people say like there's 24 drugs on this test and there's this many drugs. When I counted, there's only like 20 or 21 drugs. I just want to make sure that I know how many are on the test so that I'm not missing some.
It's all the ones that are in the PowerPoints. I'd have to count to tell you. I don't know. I can count when we're done and let you know.
Okay, that's fine. Someone just said 24, and when I was going back and counting, like I didn't count 24, so I was like, it said 24. I also had a question about digoxin, just like a clarifying question.
Yeah.
So with digoxin, you were talking about, so diuretics can cause hypokalemia with digoxin?
Some can cause
some, like the
hypokalemia.
potassium wasting ones.
Mm-hmm.
And then when you're on an ACE inhibitor and digoxin, it can cause hyperkalemia.
That's right.
Okay, I just wanted to clarify the kalemias there.
Yeah. The hypers and hypos. Yeah. Yes. And what would be considered hyperkalemia? A value of what?
Over 5.
Remember what a normal K is?
6 would be considered hyperkalemic.
Yeah, actually anything over 5.5 would be considered hyperkalemia. Cool. Good. Excellent. Let me look at something really quick here.
I had a quick question.
Yeah.
On the note of how many drugs there are on the exam, are you still uploading Alteplase?
Yes, I just uploaded it actually. In fact, I can open this and share. Let me share it with you really quick. But I did just upload it into Blackboard. So can you guys see my screen? So can you guys see this? Alteplase? Okay. So it dissolves clots. It's a thrombolytic. What does that mean? What's thrombo stand for?
A clot.
A clot. What kind of a clot? Moving
It's-
clot or stationary clot?
Stationary clot.
Stationary clot. That's right. Okay. So Alteplase is identical to human TPA, tissue plasminogen activator. And it converts plasminogen to plasmin, which dissolves clots. The important thing is that it dissolves fibrin clots. Okay. And it's used for stroke due to a thrombus. Actually, it should say due to an embolus, because we know that most strokes occur as a result of an embolus, right? Once it stops, though, and it's in the head, now it's a thrombus. So that's what it's used for. And its off-label use is to restore patency to IV catheters. Now, I think it depends on where you work. I've never seen it used for stroke, but I worked in peds, right? But if you work in the ED and you hear, and sometimes you'll hear this, they'll call a stroke code. A stroke code occurs because they want to get that patient imaged and they want to get Alteplase in quickly to break up that clot, because time equals tissue. That's the case for anything where you have a blockage of blood or nutrients to tissue. Time equals tissue. It's sort of like when you think about near drowning victims or drowning victims, right? The longer someone is submerged, the more likely they are to have deficits. So time equals tissue. So in a stroke code, they want to get the patient in, they want to get them imaged, and they want to get a clot buster in right away. Or if they have to and they need to physically go in and remove the clot, they'll do that too. So according to your book, it has to be given within 12 hours of MI symptoms if you want to break up clots that are in the heart vasculature, right? The heart arteries that feed the heart, and within 3 hours for stroke. And then adverse effects, well, duh, bleeding, right? But because it's identical to human TPA, it also can cause anaphylaxis. And then you don't want to use it with other anticoagulants because this increases the risk of bleeding. Now, if you had somebody who was on, let's say they're on clopidogrel, Plavix, because they have AFib and we want to make sure that they don't throw a clot. Well, let's just say they do anyway, even on the Plavix. And now they have Plavix on board and they have a need to have this clot, dissolved. The medical team's going to have to make a decision about what's more important, right? Risk of bleeding or getting this clot out. And maybe there's a way that they can, use Plavix and then counteract with some other things. So just something to think about. And then I found this in your prototype box too, and I've forgotten about this. I knew about ginkgo and green tea, but fish oil and ginger and feverfew, which I don't know if anybody takes a lot of that, increased risk of bleeding as well. So if people are taking these, this is again, part of your assessment is to find out all the things they're taking, not just the stuff that's prescribed or over the counter. You know, this is like, what are you ordering on the internet? You know, what are you getting at GNC? What are you buying from your uncle's cousin's sister? Right? What are all the things that you put in your mouth for, you know, health? So I hope that helps a little bit. It's a pretty simple drug to add on to your thing here. And I would probably only use it on the test in terms of making sure that you know that it dissolves clots, right? That it is not an anticoagulant in and of itself. It literally goes in and takes that bunch of platelets with the fibrin net over the top and breaks up the fibrin and breaks up the clot.
I have a quick, just like to clarify.
Sure.
So it can cause anaphylaxis because it's identical to TPA. So would that mean if you're like autoimmune, or I don't?
No, but because it mimics something human, our bodies can think that it's something human from another person, which always is a recipe for potential anaphylaxis. Just like getting a blood transfusion or anything else that's a tissue from another person, you're always going to have a risk of anaphylaxis. Good question. What else? Why do we take DIG for heart failure? What does it do?
Slows your heart rate, so less workload on the heart.
Slows your heart rate. What else does it do?
It's a
It's a-
positive inotropic drug,
Yeah.
so it increases the force of contraction.
Yes, it increases that force of contraction as well. So slowing down the heart rate, like Lindsay said, right? So the heart has more time to fill, and then increasing that contraction so that we're really squeezing blood out. Perfect.
Sorry. No, you go. Whoever.
I had a question about that because for the heart failure PowerPoint, it says that you want to decrease preload, but don't you want to have stronger contractility so that you can get more cardiac output?
You do, but if you can decrease preload, that's going to help too. Does that make sense?
Yeah, so would it be more like lessening how much it stretches while still getting a forceful contraction?
I don't think that it lessens how much it stretches, but it just increases the power of that contraction. Yeah, you're going down into the weeds, but I like the question, but we're not going to go there for the test. We're not going to go quite that far.
I have a question.
Okay.
Do we need to know the trade names on the test for the drugs?
No, never.
Okay, perfect. Thank you.
Nope, because you won't see trade names on NCLEX. So I'm never going to have you memorize those. I'll try to always put on both, but there'll always be the generic for sure. Does that make sense? Like, come on, clopidogrel, that is like awful. You'd much rather say Plavix. So I'll have both. Okay. What else?
I had a question. I was doing one of the questions in the back of the book, and are drowsiness and fatigue not the same thing?
No.
What's the difference?
Drowsiness is feeling sleepy. Drowsiness is I can't keep my eyes open, right? I'm sure when you're sleepy, you feel fatigued, But fatigue is like that kind of blah, I don't have any energy feeling. That's different than drowsiness. Does that make sense? Yeah. I would say that they kind of go hand in hand, but you could be fatigued and not necessarily be drowsy. You're probably more prone to drowsiness if you sit down and stop doing things. But those are
Thank
different.
you.
Yeah. Drowsiness is like really an intense feeling of like, I want to go to sleep. I need to lay my head down and go to sleep. And fatigue can be more of kind of, it's more insidious. It's more, it's actually a really big problem for some patients because it totally diminishes your quality of life. Right. What else?
I have a quick question about nifedipine.
Yeah.
So on the slide, it says that it increases cardiac output, but how does that produce a fall in blood pressure?
For a minute. This is in the hypertension. Is it in the hypertension lecture?
Yeah.
Okay. Let me see. Oh, it's in the hypertension. Let me go to my, it's in the prototypes. Let me look at it. That might help me. Okay. Nifedipine, calcium channel blocker. So coronary artery dilation, less oxygen consumption by the heart, an increase in cardiac output, and a fall in blood pressure. I don't know. I have to think about that. Well, coronary artery dilation definitely helps. Actually, I've given nifedipine. I've given it a lot. And it can cause vasodilation like right now for patients, which in some ways makes sense, right? Like cardiac output should be increased because your vessels are going to be bigger afterwards. So you should be able to get more, again, stroke volume, right? And beats. I don't know. I have to think about that a little bit. But don't worry about that so much.
I had the same question. I read it in the book and
Yeah.
that's what it said in the book, but I just didn't understand if the oxygen had to do with the dilation and then the cardiac output and BP were two separate things. So, but that's what it said in the book.
Right.
But
I don't know. I'm going to have breakfast with my nurse practitioner, cardiac nurse practitioner friend tomorrow. I'll ask her. Good question. I do know that it causes significant vasodilation now. And so, yeah. I've only used it in kids for like almost like hypertensive crisis, where their blood pressures are really high and you actually give it sublingually. So they'll take it out of the capsule that it comes in and send you a little oral syringe. It goes right under the tongue and it, boom, their blood pressure can drop. You have to be really careful with it, actually. You have to give it slowly for that reason. I have to think about that a little bit. I'm not a cardiac wizard, so. What else?
So throughout a lot of things, there's been an emphasis on Coumadin needing to be taken at the same time every day.
Yeah.
But I haven't seen a lot as far as why that is.
Okay. Well, let's think about this. if I take Coumadin today at 7, right? And then tomorrow, and it works for 24 hours. And then tomorrow, I don't take it until noon because I forgot. What's happening to my INR in there? So it's based on the effect that the Coumadin provides, right? So if you want to have a therapeutic blood level, right, where your blood levels remain steady so that you have a good INR, you need to take it religiously around the clock. You need to take it on its, when it's due, so that you keep those blood levels up. If the blood levels start to go down, then your INR is going to drop. Now you're not adequately anticoagulated. Then you're going to take the drug a little while later. It's going to take a while for your blood level to come back up. Now you have a period of time where you're not covered with anticoagulation. Does that make sense?
Yeah, thank you.
It's really the reason why we should take all drugs like that. But ones like this, where you're talking about messing around with someone's ability to clot, especially someone who's at risk for clot development, that's why it's so important, because that can be a game ender. Let me ask you guys a question about metoprolol. So metoprolol, what is it? What kind of drug is it?
Beta blocker.
Beta blocker. You can tell that just by its name. Is it selective or non-selective?
Selective.
It's selective for beta 1. Most of the beta blockers used for hypertension are selective for beta 1. Okay, they work on the heart. So, yep, that's true. And then there's a black box warning with metoprolol. Does anybody remember what it is?
Acute withdrawal of the drug can cause angias to become worse, and it can cause myocardial infarctions.
Exactly. So this is a drug that you don't want to run out of your prescription and just not take for 4 or 5 days, right? This is a drug that you want to take consistently. And the dose, if you're going to take them off of it, kind of like prednisone, but for different reasons, you're going to taper them. You're not going to just stop it. You're going to slowly decrease the dose over time. Good. Awesome. What's metoprolol going to do to the heart rate? What do all beta blockers do to the heart rate?
Decrease.
Yeah, lowers them. So what's usually kind of the cutoff for metoprolol? DIG is another one that can lower heart rate. Does anybody know kind of where we, below this number, we kind of go, not too keen about giving them these drugs? Anybody know?
Is it 60?
60 for adults. Okay. Now for children, it would be totally age dependent and disease dependent. But for adults, 60 is a really good one. So if you get a question that says, getting ready to give this drug, and your patient's pulse is 49, the answer is going to be hold the dose, notify the physician. Okay. And let me just clarify that too. On this test, I'm going to make sure that it's hold the dose, notify the physician. They'll be paired together, period. I don't want you to have to think about that. I don't want you to have to think, oh, do we tell the doctor? I mean, that's a practice thing that you'll figure out when you are working somewhere. Okay, awesome. So let's say I'm on taking Lisinopril, which I shouldn't take, but I'm taking it, and I start having a cough. And this cough keeps me up at night. It interrupts me when I'm trying to do exam reviews for work. What's going to happen? What do you think? What do you tell the patient to do? if that happens? Or what do you as the nurse anticipate will happen?
They should
When they come in
report
and
it
talk
and
to their
then-
physician and say, I am coughing all the time. Sorry, Emma.
That's okay. I was just gonna say they should report it and then they'll probably be switched to an ARB.
That's right. Exactly. It should be reported and they'll probably be switched to an ARB. Okay. Good. Excellent.
You would
Uh,
also get a provider order for that, right?
Oh
You would
yeah,
get a
absolutely.
provider- Okay.
But you know, if you were talking to the patient and they're like, oh, I just have this cough and I want some cough medicine. And you're like, yeah, well, you just started, Lisinopril a week ago. Do you have a fever? Do you feel, no, it's just this cough, that's the kind of thing that you would want to report to the physician and say, started Lisinopril 5 days ago, a week ago, has a kind of, we call it an intractable cough, meaning a cough that won't go away. And doc would probably just say, oh yeah, I'll write for an ARB. Switch over. Okay.
You recommend they stop taking it until they can see their provider?
No, not until, as long as they're not having difficulty breathing, they need to stay on it until they can switch over. Hopefully that's just that day or the next day. Now this is the beauty of, when you work in the hospital and something like this happens, and they switch you to a different med, boom, that med will come right up from pharmacy and you can look at when the last one was given and decide when this, needs to be given. But like if you had given somebody Lisinopril at, 8 in the morning and at 9 o'clock, the doctor talks to the family and decides, the patient decides that, oh, they should go to an ARB. You're not going to immediately give the ARB as soon as the ARB comes up because they still have the effect of the ACE inhibitor, right? So you would wait until they're ready for their next dose and then you give an ARB instead of an ACE inhibitor. These are the things that you don't think about until you're in the hospital and you're working and you're like, oh, they switched that. Okay, when do I give the next dose? So again, something that you learn when you're there, not something I want to focus on here. I'd rather the drugs here. So what's one of the side effects of Lisinopril, especially if they were taking it with another antihypertensive drug that we would be worried about?
Hypotension.
Oh, hypotension for sure. That's a great answer. It's not what I was looking for, but it's a great answer. What if they're taking it with a potassium wasting diuretic? Would there be any concern about that? Or potassium sparing diuretic?
Hyperkalemia was sparing.
Yeah, because they already can get hyperkalemia just with ACE inhibitor alone. And then you're taking it with a potassium sparing diuretic, and now you're getting the 1-2 effect, right? You're getting hyperkalemia with one, hyperkalemia with another, and put those together, and then we have a hyperkalemia problem. Okay, awesome. Awesome. Tell me about spironolactone. Is it potassium sparing or potassium wasting?
Potassium sparing.
Yep, it's potassium sparing. What side effect can it cause in men?
Gynecomastia.
Yeah, man boobs. Yes, good. Perfect. And what would we tell them about, what kind of teaching would we do for somebody on spironolactone? Besides warning them about gynecomastia, if they're male.
Don't take salt substitute or any potassium supplements and take it with food to increase absorption.
Excellent. Excellent. Yeah, be really careful about that potassium substitute or salt substitute, because it's basically all potassium that you're sprinkling on your food when you're using like Mrs. Dash or any of those. Something you need to be really careful about. Okay, what's going to make you pee more, Lasix or hydrochlorothiazide? Furosemide or hydrochlorothiazide?
Furosemide.
That's right, furosemide. What's going to make you pee more, hydrochlorothiazide or spironolactone?
Hydrochlorothiazide.
That's right. Okay, so remember, the closer to the Bowman's capsule that the drug works, right? Proximal tubule, distal tubule. The closer to the Bowman's capsule, the higher the diuresis. The further away you get out to the collecting ducts, the less. So that would really make a difference in terms of what kind of drug we're going to use. Like if you had a patient who was really fluid overloaded, came in, maybe they have heart failure, they're really wet, crackly, which kind of diuretic would you anticipate them using? Just general category. The loop diuretic, right? Loop. The loop is earlier on in that system. The diuretic we didn't learn about, but that's even stronger than furosemide, is mannitol, which is a giant sugar. And it's great, but it's used for massive diuresis. So things like swelling or intracranial injury, where we have intracranial swelling and we're trying to get the brain to shrink down a little bit, we can use that. But that's kind of potent stuff, and we don't use it all the time. How do diuretics fix blood pressure? What do they affect of the three things that cause blood pressure problems? Hypertension.
Blood volume.
Blood volume. Excellent. They decrease blood volume. Perfect.
I have
Oh,
what, Alex?
okay. I have a quick question about furosemide or just in general loop diuretics.
Yeah.
Why do they cause hyperglycemia?
Do they cause hyperglycemia, or they do cause hyperglycemia?
Why do they?
I don't know why they do, to be honest. Don't know. The more important thing is that they cause hypokalemia.
I was just gonna ask because I know hypo and hyperkalemia have a lot of the same things, like muscle weakness. So what's like the most distinguishing symptoms that you would look for?
You know what? You're not going to have a question on that because they are very close. So I'm not going to have you distinguish one or the other. The only thing I would have you do would be predict hypo or hyper based on the drug and what you know about it. Does that make sense? Like the patients on furosemide, you would expect, you know, the nurse would not be surprised to see a potassium of, 3. That kind of thing. Does that make sense? Okay. Cool.
Thank you.
Okay, what else? Let me go into hematologic, because that's relatively new, right? What drug stimulates your bone marrow to make neutrophils?
Is it
Neupogen?
Yeah, it's Neupogen, filgrastim. Neupogen is its trade name. Yep. So it stimulates the bone marrow to make more neutrophils. Why is that helpful? What do neutrophils do?
They fight infection.
Yeah, they help fight infection. So it shortens that window of neutropenia for your patient. It's used primarily in cancer patients whose bone marrow has been destroyed either by the cancer or by chemotherapy. What's one of the side effects of Neupogen or filgrastim? Can be significant.
You can have bone pain.
Yeah, you can have really significant bone pain. If you think about that, it's telling your bone marrow to rev up, right? So your bone marrow is not really like, you know, super open, spacious place. So you tell it to rev up and it's producing all of these cells. That's great. Eventually they're gonna actually spill out into the bloodstream, because remember, your bones are vascular. There are vessels that go into bones. But until then, it can cause bone pain, and it can be serious. It can require narcotics. Okay, cool. And EPO, why would we give EPO? Epogen. Why would somebody need that? Or epoetin?
If they have a low red blood cell count.
Yes, excellent. Low red blood cell count, and specifically, Kayla, low hemoglobin. But yes, low red blood cell count. And so what body part normally makes erythropoietin? Where is it made in your body naturally? Anyone? Sorry?
The kidneys.
The kidney. Excellent. So if you have kidney problems, like renal failure, and you're on dialysis, your kidney's not going to be able to sense that you're hypoxic and that you need red blood cells made. And so you're going to be very anemic unless you take erythropoietin. And then you can take it and sort of kickstart your bone marrow and make red blood cells. Okay, so hematopoietic stem cells can make three things. What are they?
Red blood cells, white blood cells, and platelets.
Amen. Yay, good, 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 good. Okay, awesome. What do we give somebody who's anemic?
I was just gonna ask, do we need to know a lot more about like blood cell formation or hematopoiesis, like in detail, or is it just we need to know that they can turn? Okay, sounds good.
Just that they can become one of those three.
Okay, thank you.
Yep. So what would you give somebody who's anemic? Bring little Johnny in. His mom's like, oh, he's such a picky eater. He only eats white bread and jelly sandwiches. He has no energy. We do his hemoglobin. Instead of being above 11, it's like 4. What does he need?
B12.
No.
He needs iron to make the hemoglobin.
Yes, he needs iron. He needs iron. So anemia and pernicious anemia. So what you talked about, Emma, B12 is pernicious anemia. I didn't give you anything in his history that would say pernicious anemia. I gave you something more that would be regular anemia, which is just poor dietary source of iron, white bread, jelly. Not really a great thing, right? And we don't all have to go eat liver, which is what, you know, my parents wanted to feed us when we were kids. We were anemic. They'd be like, oh, well, you just need some liver and onions. And they would literally fry up a beef liver with onions. It was one of my dad's favorite things to eat. And I think it sounds so disgusting. You're basically eating the organ that filters out all your toxins and poisons, right? So pernicious anemia is something that you're going to see more in someone that, yes, has a B12 deficiency. And B12 deficiency is almost always due to a lack of intrinsic factor. So the history you're going to get for somebody who has pernicious anemia is they have GI problems. They had a gastric sleeve. They just found out they have some malabsorption syndrome, right? Something like that. Actually, you can get pernicious anemia by being an alcoholic, right? You could see pernicious anemia even in someone who is anorexic. You can see regular anemia in someone who's anorexic. So iron deficiency anemia, much more common, much more day-to-day, would be kind of your go-to for anemia versus pernicious anemia, which is slow. Remember, pernicious means slowly going bad over time. So, and you don't need much B12, like you need like 3 micrograms a day, which is like nothing. If you eat, if you have good intrinsic factor and you eat any kind of animal product, you're good. You're not going to need B12. So very different diseases. Does that help a little bit?
Iron deficiency anemia, would you just give them iron, or how would you correct, like if it was dietary and his hemoglobin was really low, would you give them EPO or
Yeah, that's a great question. I think it really depends on how symptomatic they are. So the thing about iron deficiency anemia is usually people get there slowly over time, which means not slowly, but like, you know, weeks. So it's not like you have to correct it right away unless they're showing like life-threatening signs and symptoms, like they're going into heart failure because their heart is trying to pump what little hemoglobin they have around the body, and eventually the heart tends to kind of give out. That doesn't happen too much in little kids. So a lot of times we'll just try to correct again by doing oral iron and changing their diet back and then watching to see that their iron starts going up. But if you have somebody who's really sick, they might even get a blood transfusion. We might give them blood because that, boom, that fixes them right away. Give somebody a unit of blood who needs a unit of blood. I hope you guys get this experience. I mean, it is super gratifying. As a nurse, you're like, oh God, no, I don't want to get blood. But honestly, giving blood is easy, especially if you do it all the time. And again, working on an oncology floor, I did it all the time. But somebody who's really anemic, you give them a unit of blood, oh man, the pink comes back in their cheeks. There's pep in their step. They feel so much better. They have more energy. But that's pretty extreme, right? Giving a blood transfusion, that comes with a lot of, you know, it's not horribly risky, but you know, you could still get hepatitis from blood. You could still get HIV from blood, even though we screen blood. That's always a risk. So we try to do the least invasive thing to fix it. EPO probably isn't going to work because this child doesn't have iron, and iron's needed to make hemoglobin. So you could tell the bone marrow, please make more red blood cells, and it's going to be like, I would if I could, right? But I don't have any iron, so I can't. So that's the only thing about EPO. So we probably wouldn't do EPO.
So it's more just like oral over-the-counter iron pills that you would like regularly buy at like a pharmacy.
Yeah, You could do, like, in an extreme circumstance, you could do like an iron infusion. You can do some things like that. But again, you know, we're going to try to do the least invasive thing possible. So for a little kid who's picky, we're probably going to do iron, like a solution. And the only thing about when you give iron to little kids, and you guys don't have to know this, is you have to give it to them with a straw, because iron can stain their teeth. And parents don't really like that. They don't really like it when their kids don't have pearly white little teeth. So that doesn't work so well. Let me see what else. Let me go into. Looking at Dig. Okay, so Emma, I just found my hypo and hyperkalemia slide. And again, hypo is like constipation, heart palpitations, extreme tiredness, muscle weakness, numbness. If you think about it, it's kind of all things that are like less than, right? Like constipation, so your gut's not, it's slow. Heart palpitations, probably slow. Extreme tiredness, muscle weakness. Then you get to hyper, and it's more like diarrhea, cramping, heart palpitations, which again sounds exactly the same. Anxiety, but then you get muscle weakness and paralysis. So then your whole theory of how to distinguish it goes out the window. So I'm not going to ask you that. Don't worry about that. I'd rather you know the lab value for potassium, so that normal is between 3.5 and 5. And when I make something abnormal, I'm going to make it, you know, I'm not going to make it like 5.1, right? I'm going to make it more than that, or I'm going to make it much less than 3.5. The goal isn't tricky. The goal is to see if you know the material, despite what people might think. Let's talk a little bit about milrinone. This is the PDE inhibitor. Do we use it for your everyday run-of-the-mill heart failure? No, we don't. It can cause ventricular arrhythmias. It can cause a lot of problems. So it's not something that we use every day, but it does help increase the force of contraction, and it increases cardiac output. There's a very short half-life. It usually has to be given in the hospital. Again, I'm going to talk to my friend tomorrow. She puts people on milrinone, and I don't know if they send people home with like milrinone pumps. They do send people home with drugs for like pulmonary hypertension that literally you have to keep changing the drug. You have to keep the drug going at all times or the patient can die. It's really interesting. It's not one that you guys have to know, but yeah. So the big thing with milrinone is just short-term use, kind of a last-ditch heart failure med. You don't want to use it when you have hypokalemia. You want to get your K right all the time when you're doing cardiac stuff. You just do. Okay.
I have a quick question.
Yeah.
So is there any drug that you wouldn't have to really monitor potassium levels when you're giving it for like hypertension or heart failure? Or would you just monitor at all times when you're doing
I would say for the vast majority of drugs, you are going to monitor K. Now, but here's an example. I mean, I take a potassium wasting diuretic every day. But I take a beta blocker, right? So the two of those play pretty nice together. There's not really a big issue. And because I'm on hydrochlorothiazide, which is way less intense than furosemide, I might be a little hypokalemic, but not so much so that I need to have my labs checked all the time, because I don't. I would probably only have them checked if I said to the doctor, like, oh, I'm experiencing muscle cramping and I'm, you know, having all these, you know, muscle things. Then I would probably have that done. But I would say in acute care, when a patient's in the hospital and there are these things, oh yeah, they're getting their potassium checked every day. Every day. Because usually they're in for an acute exacerbation of something, right? Like, we don't just admit people for, you know, hypertension. We admit them because they have hypertension along with something else, along with something else, along with something else. So it's in those, it's when you start having multiple diagnoses and you're taking lots of different meds that we have to be really careful about polypharmacy, and we have to start thinking about, okay, this drug tends to cause this problem. We better monitor that, right? So, but I could see that if you had somebody who maybe had heart failure issues and they were on DIG and a diuretic, that they might come in for a weekly lab to check their K. Absolutely. So it kind of depends. But monitoring it or saying that you're monitoring it is never a bad answer for any drug that affects K. Does that make sense? Okay.
I have a quick question.
Okay.
So, no, atorvastatin is the secondly most commonly prescribed med.
Yeah.
And then I wasn't sure, I forgot what the first one was, and I looked it up. And is it hydrochlorothiazide or lisinopril?
You know what? It depends on what you look at, what list, but they say lisinopril is the number one.
Thank you.
Yeah.
I had a question about Arbs. So
Yes.
I know that some of the drugs for hypertension, like Arbs, can cause hypoglycemia. Why can Arbs cause hypoglycemia? But I guess ACE inhibitors, that's not something that's listed for them. I know that they act at different points in the pathway, but they seem so similar in their actions that I guess I'm just confused.
Yeah. You know what? I'm gonna have to look at Arbs and see. I'm guessing that it has to do with, because remember, Arbs block angiotensin 2. And angiotensin 2 does two things. It causes vasoconstriction and it causes the reabsorption of sodium and water. And I'm guessing that there's something related to that causes hyperglycemia, but I don't know. So I'll have to find out and I'll let you know. But I don't know for sure. Does that make sense?
Yeah, thank you.
Yeah. It's not high on my radar, obviously, for things to test you about. Okay, I have about 5 more minutes and then I got a jet. They moved trivia to 5:30. We're doing it tonight. It's awesome. What's the number one Halloween candy? Anybody know?
Reese's peanut butter cups?
Yes, it is. Peanut butter cups.
I totally
Yes.
get that.
That's the number one. So what is the Halloween candy that's like cilantro? You either love it or you hate it. Anybody know? Been a lot of stuff on Instagram about this lately. Just my Instagram, which is probably boring and stupid, but
I feel like almond joys are a big one.
that's true. They could be on there, but nope, it's more common than that.
I was gonna say candy corn.
Yes, it's candy corn. Woo! Yes, people either love it or hate it. Anybody love it? I love it. Love candy corn. even got sick on them as a kid and puked up candy corn everywhere. Still love them. Okay. I'm trying to think if I have any other good questions for you. Yeah. I don't want to give away all my secrets. You might call me. Go ahead.
I'm so sorry. I just had a basic question about the test. Is it going to be like the same format as last time with 1 free response, 2 like choose all that apply, and then
Yes.
multiple choice?
Yes. So you'll have a few select all that apply. I probably won't have more than 2 or 3 at the most. And what I want you to know about select all that apply, and our last test didn't do a great job of it, so I turned it into a bonus question, but I'm gonna try to make it very cut and dry. I just failed last time. So there will be a few. There will also be a few math problems. Okay. So, but they'll be basic, kind of like they were before, nothing crazy. Just want to see how you're doing with that. Math doesn't go away, so it's good for you to know. It's a really important part of farm. I'll probably have another essay question again, similar to the one that I had before, in which the entire class all got credit for. I'm trying to think. Yeah, this will be more drugs, right? It'll be more drugs and more, and you're going to want to put on your thinking caps and think critically about things, especially when I give you a scenario of some sort. You know, patient blah, the nurse blah. So, yeah, but it'll be a mix. It'll be a mix of straight knowledge and application. I'm not going to give you all application. By the time you get to senior year, you should really be at all application and analysis, really digging deep on those questions. But you guys are still learning. And I know there's a lot of drugs on this test, but the good thing is you're going to have this set and you're going to be seeing them again next semester, right? And seeing them and learning more about the body and drugs, etc. So I'm hoping that this is laying a little bit of a foundation for you that you can at least kind of remember the drugs. Okay. Anybody go to clinical this week and see a drug that we've talked about? Yes, I see heads nodding. Cool. What'd you see? What did your patients take? You can just pop out the name of the drug if you want.
My patient was allergic to furosemide.
Wow, really? That's a bummer. It's not a good thing to be allergic to, but good. Okay.
My
Awesome.
patient was allergic to lisinopril.
High five. Me too. That's the only thing on my drug allergies. Okay. Well, you're going to start to find out that your patients are on a lot of what we've been talking about. Okay. So it's good. One of the things, I'm still grading your concept maps. And it's so fun to grade them because I forget that you guys are first semester nursing students because you're so smart. But it is funny, like one of the things that I'm seeing is that pretty consistently people don't have their meds linked to anything. And it's like, we're giving them for a reason, right? So link it to something, link it to a symptom, link it to pathogen, link it to a lab, right? So that's okay though, because this is good. And I was just already, I've probably done, I don't know, 10 or 12 of them and totally impressed by how much you guys know. You're already a little You are nurses in the making. It's very obvious. All right. Well, if you guys think of additional questions, email me. And I may email the class out the question and the answer. I won't identify you, but just so that everyone can benefit from the question. And I'll let you know when the test is ready for upload. Going to work on it tomorrow. So I'll let you know. Okay. Any other questions? Are you staying warm? Dry? Do you have your fuzzy socks on? Okay. Awesome. I'm totally digging this weather. Love it. My neighbor's house across the street has these 3 giant trees that are just flaming red, just flaming. So pretty. So I hope you get some fall in. All right, guys. Well, I will see you Thursday, but feel free to contact me if you have any questions. If we need to Zoom or whatever, we can do that too. All right. Okay.
Thank you. Good luck at trivia.
Thank you. If you win, you get to host it. So we're happy that we're not going to play tonight. All right. Bye, guys.